Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 452 of our pharmacotherapy series, which majors in lung cancer. The first case in this video focuses on patient LML from part 451 of this pharmacotherapy series. LML was started on erlotinib therapy based on a positive epidermal growth factor receptor mutation and, within 8 weeks of therapy, had obtained a partial response. So my first question to you reads: what benefit from erlotinib therapy can LML expect in terms of prolonged survival? Although there is short-term benefit for patients with epidermal growth factor receptor mutation positive tumors to receive erlotinib, it is not yet clear if there is a longer-term benefit. The response rate for erlotinib treatment is approximately 67%, time to disease progression is 11.8 months, and overall survival is approximately 24 months. As of yet, there are no data to support that treatment with small molecule inhibitors prolongs overall survival relative to doublet platinum-based therapy. It is much easier to demonstrate an effect on tumor response and time to progression, such as with erlotinib, than it is for overall survival in most cancer studies. Showing improvement in overall survival is difficult because study subjects who are randomly assigned to one arm of a study can exhibit progressive disease and could hypothetically cross over to receive the competing treatment once they are classified as off-study. The competing treatment could prolong overall survival and confound interpretation of the overall survival benefit for the test treatment, e.g., erlotinib. Further study is required to establish the benefit of erlotinib or afatinib treatment on overall survival. There is also no evidence to show that addition of erlotinib to chemotherapy is superior to either treatment alone. Hence, at this time, treatment for LML, single-agent erlotinib, would be expected to prolong her progression-free survival. But it is not yet known whether erlotinib prolongs overall survival. If LML's tumor was classified as having wild-type epidermal growth factor receptor instead, what treatment should LML receive? If the biopsy results had shown that the tumor epidermal growth factor receptor was wild-type, i.e., no mutation, then LML would be considered for a platinum-based doublet. Because her disease is non-squamous, the adjunct agent selected would most likely be pemetrexed. Scagliotti and colleagues randomly assigned patients with advanced stage non-small cell lung cancer to receive either cisplatin plus gemcitabine versus cisplatin plus pemetrexed. Although the median survival time was similar between the two arms, there were differences depending on tumor histology. Patients who received pemetrexed and had adenocarcinoma experienced a median overall survival of 12.6 months, whereas those who received gemcitabine had shorter survival. In contrast, those with squamous carcinoma who received pemetrexed experienced a 9.4-month median overall survival, whereas those who received gemcitabine had longer survival. Therefore, if LML's tumor had been wild-type for epidermal growth factor receptor, she could receive cisplatin and pemetrexed as first-line treatment because her disease is adenocarcinoma. Consideration could also be given for using cisplatin and paclitaxel together with bevacizumab. As mentioned previously, the latter agent is approved for use only in patients with non-squamous cell non-small cell lung cancer. Those who respond to treatment with 4 to 6 cycles of cytotoxic therapy should receive maintenance therapy with pemetrexed and bevacizumab afterward based on the AVA-PERL trial. The adverse effect profiles for cisplatin and carboplatin differ from each other. If a platinum-based regimen had been selected instead of erlotinib for LML, what characteristics about LML could be used to guide the selection of carboplatin versus cisplatin? Cisplatin is predominantly associated with ototoxicity, nephrotoxicity, and neurotoxicity, whereas carboplatin is predominantly associated with myelosuppression. This would be her first cycle of chemotherapy. Therefore, she is not expected to have depleted reserves of myeloid progenitor cells. Her estimated creatinine clearance is 48 ml per minute and, based upon this, would be considered to have moderate renal impairment. In this case, carboplatin may be preferred over cisplatin because it is associated with less renal toxicity and it is dosed according to the Calvert formula, which accounts for renal function. Total carboplatin dose, in milligrams, is equal to AUC multiplied by opening brackets GFR plus 25 closed brackets, where AUC is the area under the concentration time curve and GFR is glomerular filtration rate. A typical dose of carboplatin in this setting would be determined based on an area under the concentration time curve to account for renal function instead of the typical weight, or meters squared based dosing. The area under the concentration time curve targets are commonly 4 to 6 mg per milliliter times minute for most doublet regimens. If a patient with moderate renal function were to receive a fixed dose that is similar to that given to a patient with normal renal function, then systemic exposure would be higher. This higher exposure could result in greater toxicity, notably greater myelosuppression. By dosing the drug according to the patient's renal function, the risk for overdosing a patient with decreased renal function is minimized. For example, if LML's carboplatin dose is ordered as area under the concentration time curve 5 mg per milliliter times minutes, then her dose would be calculated as dose is equal to 5 mg per milliliter times minute, that is 48 mg per milliliter plus 25, which is 365 mg. In contrast, if her renal function were within normal range for estimated creatinine clearance, e.g., 100 ml per minute, her carboplatin dose would be 625 mg, that is approximately 70% higher. Several different methods may be used to estimate renal function, such as the Cockcroft and Gault equation, and the dose calculations will differ according to the method chosen. The American Society of Clinical Oncology, abbreviated as ASCO, has developed recommendations for the dosing of carboplatin. It is recommended to cap the glomerular filtration rate or creatinine clearance at 125 ml per minute within the Calvert equation. Usually, the choice of method is institution-specific, because there is no evidence to show that one estimation method is superior to the other. By consistently using the same formula, providers reduce variability in systemic exposure and thus increase the predictability of tolerance to the drug. If the patient's glomerular filtration rate is estimated based upon serum creatinine measurements by the isotope dilution mass spectrometry method, then the glomerular filtration rate should be capped for a maximum of 125 ml per minute, because serum creatinine values can be underestimated when they fall below 0.7 mg per milliliter, as can happen in some patients. The FDA issued this safety alert to avoid administration of high doses to patients with normal renal function and thus likely avoiding drug-related toxicity. In conclusion, LML should receive erlotinib as first-line therapy. If her tumor had contained wild-type epidermal growth factor receptor, instead of mutant, then a platinum-based doublet, i.e., cisplatin or carboplatin, could be considered with pemetrexed therapy. She has moderate renal impairment. Therefore, an agent such as cisplatin would not be favored because it is associated with a high incidence of renal toxicity. Carboplatin would be a safer choice because the dose would be selected based upon her renal function, and is associated with a lower incidence of renal toxicity than cisplatin. LML experienced minor-grade diarrhea and skin rash and otherwise tolerated erlotinib treatment very well without any impact on her daily activities and quality of life. LML continued erlotinib therapy, and at 9 months, there is no evidence of disease progression. The plan is to continue this therapy until the disease relapses. So my next question to you reads: what types of side effects should LML be monitored while receiving erlotinib therapy? In general, therapy with erlotinib is well tolerated, especially relative to cytotoxic chemotherapy. Diarrhea and rash are the two most common adverse effects of epidermal growth factor receptor tyrosine kinase inhibitor therapy. The diarrhea can be treated with loperamide in most cases. Rash requires intervention in approximately 1/3 of cases, and it is desirable to treat it with agents such as 2% topical clindamycin, minocycline, or doxycycline, and topical 1% hydrocortisone. Erlotinib dose reduction, in 50 mg decrements, could also be considered, although this would likely shorten the anti-cancer benefit experienced with this agent. As mentioned earlier, non-small cell lung cancer is primarily a disease in those older than 60 years. LML is 85 years old, and there is concern that patients, particularly more than 80 years old, may not tolerate cytotoxic chemotherapy as well as younger patients. Hence, elderly patients are often undertreated. However, recent studies suggest that survival benefits are greater in elderly patients who receive doublet therapy versus single agent. More studies of various regimens are needed that would focus on treatment of elderly patients, particularly effects on survival, quality of life, and tolerability. Such studies would investigate the best clinical parameters that enable prediction of response and tolerability to therapies, and also the doses associated with the best outcomes. Because the majority of patients have wild-type epidermal growth factor receptor, cytotoxic chemotherapy is first line. Therefore, considerations must be given to patient preferences, comorbidities, and performance status. It is not uncommon for those with advanced age to live alone. caretakers who could help the patient monitor for and treat adverse effects of chemotherapy, dehydration from diarrhea or vomiting, febrile neutropenia, etc., would be an essential consideration, particularly in this population. Even though LML is able to continue treatment beyond 9 months, most patients eventually exhibit progressive disease within 1 to 2 years. These patients can often be re-biopsied. Approximately 40% of these cases develop secondary mutations in epidermal growth factor receptor that render the tumor resistant to erlotinib treatment. At such time, consideration can be given for second-line treatment with afatinib. In addition to epidermal growth factor receptor mutation testing, LML's pathology was analyzed for ALK fusion rearrangement. If this returned positive, how would that impact the initial choice of treatment for LML? Anaplastic lymphoma kinase, abbreviated as ALK, rearrangement consisting of a fusion of EML4 and anaplastic lymphoma kinase is a predictive marker that is present in 2% to 7% of NSCLCs and has been validated to identify patients who may benefit from anaplastic lymphoma kinase inhibitors such as oral crizotinib or ceritinib. Patients are more likely to be anaplastic lymphoma kinase positive if they are never smokers or have adenocarcinoma histology. Therefore, it is standard of care to determine whether anaplastic lymphoma kinase rearrangement is present in all patients with adenocarcinoma histology. Initial therapy with crizotinib resulted in an improvement in progression-free survival of 10.9 months versus 7 months for patients receiving platinum pemetrexed doublet chemotherapy. Additionally, crizotinib has been shown to improve progression-free survival over chemotherapy in patients who have already received chemotherapy in the first-line setting. Recently, a new oral anaplastic lymphoma kinase inhibitor that is 20 times more potent than crizotinib, ceritinib, was approved for treatment of patients after progression on therapy with crizotinib. The anaplastic lymphoma kinase inhibitors are generally well tolerated, with the main adverse events being visual disorders, nausea, vomiting, diarrhea, and fatigue. The visual disorders usually present within the first 2 weeks of therapy and most commonly present as flashing or trailing lights and the presence of floaters. In conclusion, initial therapy for non-small cell lung cancer is predominantly focused on initial staging, role of therapy, and then histology present. After progression of disease, there are many chemotherapeutic options that may result in some progression-free survival, although overall survival is still dismal. Recently, a new targeted approach to the treatment of progressive non-small cell lung cancer was introduced with the approval of nivolumab. Nivolumab is a programmed cell death 1, abbreviated as PD-1, receptor inhibitor that gained FDA approval for advanced, previously treated squamous cell non-small cell lung cancer based on the CheckMate 017 trial. This trial demonstrated an improved overall survival in patients receiving nivolumab over docetaxel, 1-year overall survival 42% with nivolumab versus 24% with docetaxel, hazard ratio for death of 0.59 with a p-value less than 0.001. It is expected that the use of PD-1 inhibitors will expand beyond squamous histology as well as exploring a role in first-line therapy. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 453.